We'll do a little bit of back and forth. I'll probably do the first half, and then Reese will jump in. So you might see us kind of moving in and out. It came about from a need that we noticed earlier in the year when we started doing some awake non-intubated proning on our COVID patients, and started to we needed to have a staff who were doing this. And we started developing our awake non-intubated proning guidelines that we are using now, as well as what do we know about proning already along. We'll start talking a little bit about what are we learning about proning amidst COVID-19. What are some current recommendations? What are the gaps? And our physio group did a little video that we will show you as well. So what do we already know about hypoxemia? Is really a disease which has three distinct, can occur in the lung tissue in various parts at different times, which is really what makes ventilating these patients so difficult. This leads to decreased lungs and the rest of our body. So ARDS management is really focused on the principles of lung protective strategies, again, which is really common out, and these really trauma, decreased tidal volumes to reduce the effects of valia trauma on our patients' lungs, as well as the use of semi to prevent this damage that can occur to the alveolar walls. Knowing that, what we know about ARDS management and lung protective strategies, and all of our other critical care stuff that comes along with it, such as decreasing demand. What we know is that we also do adjunct therapies to improve our ability to help our patients oxygenate, and those would include things like the use of nitric, which is a pulmonary vasodilator. Perfusion matching is that it helps us recruit our dorsal alveoli. So it helps us recruit a supine position. It also helps us shift fluid. So in the supine position, again, just due to gravity, our patients tend to have more edema and inflammation process. So not necessarily due to play a part. It's really more about the physiology of the inflammatory process in the lungs. It also helps to reduce pressures, so lung compliance on your lungs when you're supine. When you're prone, the lung actually isn't pushing into the lungs, along with the abdomen is no longer pushed. Do with recruiting our used in the supine position, shifting our fluid, decreasing pressures, and all of those which help with more perfusion to our alveoli. Is really the impact of proning on ARDS management and why we should be doing it all the time. Now, and so that's why it's not that we just as we possibly can, but it is it's a clinical judgment that's made with an interdisciplinary team and really based on the patient, the status, the physiology of their ARDS, and all that kind of stuff. Where it helps with BQ mismatching is ARDS with even worse oxygenation. And the reason that they think the oxygenation part is prevalent is the viral inflammatory response sites. And this causes a significant inflammatory response, which leads to the ARDS piece that we talked about. We're finding walls. There's more pulmonary edema from the inflammatory process, and there's this lung angioedema that we see, but not to this degree in our that patients who have COVID-19 and are starting to develop respiratory symptoms, they tend to deteriorate quickly, and I'm sure attest to seeing this happen. The transference to a critical care area that can manage why we're seeing the silent hypoxia. The other interesting part, breathing hard or breathing fast, shallow breathing, but what we're noticing in the COVID-19 patients is that they can look kind of normal, maybe starting to, not starting to, I should say, it's probably already happening, but that's something that is definitely a higher priority to help manage the BQ mismatches, those silent hypoxia patients. Okay, so what are we starting to learn? Well, I kind of have already gone into that a little bit, but we're learning that because their patients are not always having the acute respiratory distress, they're able to actually prone patients who are struggling to kind of get me to lie on my stomach, but always having that acute respiratory distress, they're willing to prone, and they don't feel as it also helps to potentially even keep the intubation at bay. Reese is going to talk later about a patient experience that we had here and now being able to has shown benefit, in the research, and of course, anecdotally, we have also seen that here.
Hi, nice to meet everyone. Decision support tools and recommendations out there. The ones that we came into contact with were from the UK, from Italy, and also I'm predominantly in New York. So what we did was I've collaborated, but what I really recommend is listening to your staff in your areas to try and understand what their concerns are, because I think a lot of the conversations and questions I get asked are at the bedside about criteria. I'll kind of end this on a patient, and 28% should be considered for awake proning. But they actually concluded that any patient suffering from COVID-19 with the risk proning and could be inappropriate with what we're trying to ask them to do, just so I can get an idea of how much staffing we'll need to be able to support the maneuver, and if they're able to communicate as well, so I can know if they're coming to do just specifically that to another member of the team. So exclusion criteria and kind of absolute contraindications, as Simmie mentioned, if we're thinking about that kind of asthmatic who's in that respiratory, including somebody who has acutely getting worse, need to kind of be intubated imminently. This isn't a rescue. This is trying to prevent this. If they've got a systolic blood, they're in arrhythmia, then that's a consideration. The level of agitation in that position, rather than turning themselves back over, and just with line management, we want to make sure that they can remain there. Any unstable spine, thoracic surgery is the final. We can use pillows to offload, etc. So then the things that we're monitoring throughout is the patient comfort levels and tolerance, and able to stay in those positions for aware of. And then also kind of their hemodynamic instability throughout. And I'm typically looking within the first 10 to 15 minutes after I've prone somebody, as that's usually when they're going to present themselves. To be escalated, does the team then need to be involved? The risk associated with little, I think line management, but through the video that we recorded, and trying to disconnect as much as you can prior to the actual as well. But what we're finding is it's not actually requiring an increased amount of staffing to perform the maneuver. We can do it with 2 individuals at one, or if not 2, should be doing this for. The guidelines recommend anything between 30 to 120 minutes in each position, providing that the patient can tolerate it. I tend to recommend side, and that's absolutely fine too, over a 2-hour period. The other thing that I'm finding as well is the position that you place patients prone to communicate. That's nerve injuries. So then for us, the next thing is kind of where are the gaps in our knowledge and where are the gaps in our practice? And I think it's clear that more research is of this. The patient that quickly identified that this patient was appropriate to be proned. So when they came to us, we turned them onto their front, and there was no immediate reduction in the FiO2. Their saturations were stable. I think sometimes it's important to realize that by not moving backwards, sometimes you're actually moving forwards. And over those next couple of days, over this week, what we've really found is that we had a patient for her, which was just critical. And today we're looking at mobilizing her and getting her moving. She's on 30% FiO2 via Optiflow, and is doing incredibly well. Search, are we proning? And then, of course, requirements are increasing, or when they're... And then the time and position that the patients are in this. At the moment, we're doing anything between 30 to tolerate, but for me, it wasn't yet. In one of the references, there's research that's done out of Alberta, and they're saying that the strength and evidence to support awake proning at the moment is undetermined when we look at outcomes such as some intubations, as that's clear kind of from the patient populations that I'm treating at least this week. But there's definite gaps in our knowledge, and we're looking to fill that over time. We recorded a video. It's about 3 or 4 minutes. A lot of information that's at CACCN. Be encouraged looking towards your institutional policies and proceed to share those, and we've included that, but we'll just pop on that video now.
Hi, my name is Reese. I'm one of the physiotherapists working at Vancouver General Hospital. So I'm just going to go through the actual movement of proning somebody. We're going to assume that we've spoken about the risks associated with it. We've checked precautions and contraindications, and the team are happy for us to do an awake proning. I've spoken to the patients. I've already got consent. We've kind of gone through that with the presentation. So the first thing we're going to get the patient to do is just move over to the other side of the bed. In this instance, we have an arterial line in the right radial. We also have the Foley and the OptiFlow. So I've just made sure on the OptiFlow that the connector, the patient isn't going to lie on it just to prevent any pressure points on the side of their face. I'm going to bring the arterial line across the bed in anticipation that that's where it's going to end. And finally, I'm going to put the Foley on that same side just so all my lines are already pre-managed. And at this point, because the patient's mobile, they might need a little bit of support just to get to that side of the bed. So I would recommend doing this with another colleague on the other side. And you can support the patient to move over to the opposite side of the bed that you're going to turn to. So Ruby, if you'd like just to move over to that right-hand side, nice and slowly, perfect. And at this point, I'm just going to encourage the patient to start a roll. So I'm going to get them to bend their right leg up, and I'm going to get them to reach over with their right hand, making sure that the line is always visible. Make sure there's enough slack. And at this point, I'm just going to get you to turn over, and I'm going to help with that. And the most important thing is keeping that underlying arm as straight as possible and tucked in against their body so that nothing gets caught. I want to disconnect any IVs as well prior to this movement. And on 3, we're just going to kind of turn onto your front, like so. And at this point, you can also help by just pulling through with this sheet to kind of encourage them onto their front. And Ruby, if you're able to, I'm going to bring this hip down and then come through with this shoulder. And I'm going to support this shoulder as we come through and as we bring this arm round. At this point, the patient's kind of all the way towards the right-hand side of the bed. So I just help support them to move them into the center. Just going to shuffle you across. That's wonderful. We teach feeding the apple here. So I want this arm less than 90 degrees as well as the elbow with their hand in a neutral position. And what I'm going to do is I'm going to get Ruby to straighten her elbow, rotate it, and kind of bring it down by her side. This is a nice position, but just to finish it off, I'm going to make sure that there's a sheepskin underneath her head because I don't want her cervical spine to go into too much extension. So I'm just going to get you to lift your head up here. And then what I also encourage is to offload the hip because that's a common pressure point. So I'm going to put this underneath Ruby to offload that hip entirely. You can also put a pillow underneath the shoulder if you need to. And I'm also going to support this knee. And finally, I want to offload the pressure support on the ankle. So I'm going to offload that entirely now. And then to further optimize the patients, what we can also do is actually tilt the entire bed. So at this point, we're still maintaining a nice position, 30 degrees. How does that feel, Ruby?
It's good.
Yeah, I've got clear visual on all of my lines still. There's no pressure points around the OptiFlow, and everything else is very visible for that. And then when it comes to, we'll probably leave a patient in this position for 30 to 90 minutes, depending on how they tolerate it. Turn them to the other side, and then rest them in supine and sitting upright. Yeah.
Thank you, everybody.
Thank you.
If there's any questions, we're happy to help. Otherwise, good.
I have one question. I was wondering, were there a number of patients you were able to avoid intubation on by doing awake proning?
Definitely, so far the one that we did earlier this week, and in the March months, we were able to ward off, I'd say about 3 that I know of. I don't know, Reese, if you have a.
Yeah, it's something that we haven't had stats on specifically, but it would be interesting to go back through and get an idea of percentage-wise of those patients that we kind of anticipated might have needed intubation, and then we're able to help prevent that. Unfortunately, I don't have specific numbers, but yeah, I think around those kind of at least 3 that I know of, if not 4.
Yeah. We're hoping now that because this will all be through the ICU database, of course, as well, which will help. But I think the other thing was that we didn't really, when we knew about it, we were like, oh yeah, this is a great idea. But it kind of took that knowing that other sites were doing this. And it was, I think it was really when Italy showed their, some of their research with the awake proning. And so that was kind of what was, I know when Reese kind of was like, hey guys, should we do this? And everybody was on board to, try anything at that point. So we're hoping some of the
longer stuff will be caught through the ICU database. But yeah, again, another gap in what we know about this so far.
Yeah, here we are.
I think one of the other interesting things I found was around the staff at the bedside, and that we prone quite frequently for our patients that are fully sedated and ventilated with multiple lines. And actually, when we took away those lines, took away the sedation, that was the challenging part, is how do we do this with someone who's awake, who's able to engage with us, which was kind of funny when we were thinking about it and looking at it. But I think now that we're getting more familiar with the kind of profile of this virus, and at the bedside I'm seeing kind of that confidence as well. So I'm not sure if other centers are having that too, but that's definitely what I was seeing initially in the early stages anyway.
I think it's definitely a bit of a culture shift. That picture that I had in the presentation was actually fully intubated patient on ECMO that we proned, that nobody questioned because it's just so normal. Yes, we should prone this person. And then the patient that's talking to us on 70% FiO2 was like, what? And so that's definitely a bit of a culture change. And now, though, the cool thing is that we're seeing nurses kind of almost bring it up on those higher patients that are awake on FiO2, but otherwise kind of okay. And I think that's where that shift it's definitely a shift set. And I think in critical care, we get so good at critical care, and then we think, well, that's not sick enough, so we shouldn't go there yet. From reading the chat, sounds like everybody is having very similar findings. And I think that means good that we're doing similar things, which is awesome.
And fantastic that we're sharing our solutions and our stuff with each other. I just love that. It makes my heart happy.
Yeah, absolutely.
Yeah. Thanks so much, you guys.
Thanks for watching, everyone, and thank you for joining us on the BC chapter of the CACCN YouTube channel. We have a lot of great content from previous events we've had over the past 12 months. I would suggest subscribe and hit the notification button so you can know when the next thing is out. And if you ever want to come to our next event, we're on Facebook and on Instagram. Our links are listed below. And while I'm on the topic, if you're a critical care nurse anywhere in Canada, why don't you join CACCN? We have a ton of resources to help you be the best critical care nurse you can be. Go to caccn.ca and join us.